Good morning, Carbon County. Thank you for joining us for our third physician panel speaking about COVID-19 and how it directly affects us in Carbon County. With us this morning, we have Dr. Charles Cunningham, Dr. Dwayne Abels, Dr. Edward Zimmerman, Dr. Greg Johnson, and Dr. Stephanie Chu. So with that, I'm going to let Dr. Abels get us started this morning. Dr. Abels?
Good morning, everyone. So last time we were here, you asked a question out of the audience about how long droplets suspend and everything. I did multiple site searches, and we still have no definite data. It seems to be a few seconds to a few minutes. The mask also is to help not you to protect you, but to help not you to spread the virus, particularly if you're asymptomatic. Because they had done studies with masks. Instead of coughing droplets 6 feet, what happens is that the mask gets it only out about 6 to 12 inches and less a volume of droplets. So that is why we're wearing the masks, to protect other people. These masks, unfortunately, will not necessarily protect you from getting droplets. It reduces the risk, but does not protect you. So social distancing is still crucial, even when you're wearing a mask. And wearing gloves in the environment, you wear the gloves, but basically gloves have to be washed if you use them. They really don't protect you much. Hand washing before you go to the store, after you go to the store is the most important factor. Soap and water works better than the alcohol sanitizers, but if you don't have soap and water, use the alcohol sanitizers.
Another advantage of the mask is that it keeps you from touching your face, or you're more aware of your face, I think.
I agree.
We know that's one of our biggest transmissions, so if you wash your hands well and don't touch your face, or you can wear the mask to remind you not to touch your face, but it does the same.
Even though we don't have masks on right now when we're in the hospital, otherwise we're wearing them all the time, which is a little problematic for patient care, but it's very necessary, and we encourage people to utilize masks when you're out in public as well.
And the visitation, of course, is difficult for families, and I understand that. And we've had some feedback on the difficulties families have experienced, which is painful for us as well as you all out there. People have died in hospitals across the nation, and sometimes some hospitals like in New York, nobody's there. Here we allow somebody to be there, but a lot of people in this town have extended families, and this is hard. We appreciate that and realize that. We don't like doing this, but we have to try to protect the staff, visitors, and people in town when you leave the hospital as a visitor.
So public health orders were changed a couple days ago, as you've all seen in the news and in the paper. I'm public health officer for a different county, and so I'm familiar with them. The changes were made by the governor and with consultation with our state health officer, Dr. Harris. Daycares were reopened with restrictions, and so originally it was just for those people that were considered essential, their kids could still go. And so those are now reopened with limitations as far as the number of kids can be in a room and such. And they still have to take temperatures, and staff has to wear masks and such. They reopened the restaurants for carry-out service as opposed to just curbside. There's still no dining in. The 10-person limit for gatherings is still in place. And then most importantly for this area for sure is that a lot of the service businesses such as hairdressers and salons and nails and massage and such, those have been reopened with restrictions, as they often are just one client at a time. But again, there's no waiting in the waiting rooms for them, and there's a lot of restrictions there too, but at least these businesses are slowly reopening. And from a public health perspective, because they're reopening, we really want to have a lot of testing done. So that if someone's symptomatic with symptoms of coronavirus, we would recommend that you think about getting tested, even if you're not that ill, mainly because we want to know if there's a surge in cases after we relax these recommendations.
And the testing, that's obviously been a very frustrating issue during the past 6 weeks or so. We currently have increased ability to test. We don't get the results back immediately, but at least we're catching up a little bit on our ability to test. You might read a lot of different testing recommendations or parameters, or you'd see it on the news. We do have one of the quick or point of care tests available, but we're limited to use that only for severely ill patients that are being hospitalized. So we cannot use that for the general public on an outpatient basis, but we do now have the ability to send off testing to the Wyoming Public Health Lab. There's not a definite turnaround time for that, but can be as early as one day, can be several days, kind of depending on how busy the state lab is, but we're definitely making improvements along those lines. One thing for everybody to be mindful of with states starting to relax the stay-at-home requirements. We didn't have that as an official mandate as opposed to Colorado, but that doesn't mean that this whole issue is necessarily improving or going away. There's the risk of a increased surge or increased cases when they reopen things, and we have to reopen things at some point, but people should not have a false reassurance that this is behind us.
We do have limited test swabs still. Certainly we had like 20 before, now we've got 100 plus now. And so we can do more screening. If people want to pay for a test, we can send it to a private lab, but there is a cost to that. If we send it to the health department, there's no cost to the patient. So those are what we have to work with depending on what we can do for you guys out there.
There's no cost for the actual test, but there might be for the evaluation and sample collection and such.
Okay, so one of the questions that's come through is models have predicted that we will see a surge beginning Friday, May 1st. Is that true? And if so, is the hospital prepared for that surge?
The surge is predicted in most models that are selected as these groups that I listen to as reliable is March 1st through March 5th. One is March 1st, May. I went back to the future. Oops, sorry. May 1st through May 3rd is one model, May 1st through May 5th is the other model. And that is still currently there. We have a surge plan in place. Fortunately, we have not had to use it. We've had one serious COVID patient in the hospital that was from out of state. And that patient is transferred to Wyoming Medical Center. We do have some home isolation of some positive COVIDs in our county. We are monitored, public health is monitoring them appropriately. Christina Baugh is also monitoring them from the hospital. So far, those 3 patients are doing well. The other people we tested in that contact group have not tested positive. So maybe we have contained this small surge.
Well, one thing to keep in mind, if you look at the statistics on the Wyoming Public Health website, when it's only listed as, I still think it's 4 for our county, but that doesn't reflect necessarily the number of positives that we have had. For instance, if somebody is here as a contract worker from out of state or out of the county, and they test positive, that's assigned to their home county, not assigned to us. So, once again, that's something that we shouldn't have false reassurance about, that we've only had 4 documented cases in the county. We've seen a lot of ill patients that we previously were unable to test for, and like I said, we've had other ones that have been positive that are assigned outside of our county. So, even though I think everybody's done a good job with the social distancing and trying to contain this, don't get false reassurance that there's only been 4 people within the whole county that have had the COVID.
We have had, and with this though, with the question about were we preparing for the surge, this is an example of a small surge and we got it contained. So hopefully we'll be successful if it occurs again.
And also in the hospital, we're prepared. So we've made a lot of preparations in terms of, separating the physical space, working on staffing models, having a lot of different things in place that if we should have the surge, we would be prepared, or as prepared as we can be. That's kind of the problem that we've run into across really the world, is that we don't have enough healthcare providers. So as with our limited resources that we have, we're going to be as prepared as really we can be.
And I wish to thank those nurses that are retired that have volunteered to be here to help us.
So following up on that then, can you speak to, in more detail, what specific steps MHCC has implemented from start to finish to deal with a COVID positive patient? Can you describe what that looks like from the time they're entering the facility through that entire process?
And so I would say even, in the clinic, and so we have the whole process set up from even when they come into the clinic and then need to be brought over to the hospital. So in the clinic, we have designated rooms, we have designated screeners who wear all the full protective gear, and then that way there's a lot lower chance that they could become sick then and then infect other people. We have specific areas that are designated that get cleaned in between each patient to make sure that then if there are any patients who did have coronavirus that was spread, that then the rooms are terminally cleaned, which would then prevent the spread from anyone else who would enter that room. With that, then they do talk to the emergency room physicians to kind of let them know, hey, by the way, I have a patient that I suspect has COVID. If they are sick enough to then need to be hospitalized. If they're not sick enough to need to be hospitalized, they then would send them home with oxygen, but then also let everybody know, because then that way we can kind of check in on them frequently. And then so I guess you guys would be able to speak better on the emergency room.
Yeah, from the standpoint of start to finish, anybody that enters the hospital is screened with the temperature, as well as being asked about symptoms. That includes employees. We keep a log of our temperature twice daily and have to report to our infectious disease coordinator, Christina Bond. So when somebody shows up to the hospital, they're initially screened. If they're being seen in the emergency department, if they have fever or other symptoms suggestive of COVID, we have designated rooms in the emergency department with a barrier that's been constructed. We have 2 rooms that have negative pressure, meaning that there's a special, essentially air circulator that goes directly to the outside. People are, when they're put in the rooms, they have to stay in the room, and then we try to, we have the initial screening and triage like we normally do for all ER patients, and try to minimize going in and out of the rooms. We have 1 critical bed in the ER that's once again walled off specifically for infectious disease precautions. You'll see all of us wearing a lot more attire, especially on the side where we're worried about potential COVID patients, with a face mask or a face shield, a face mask, a gown, gloves. So we have a lot of precautions in place. Even moving patients about in the hospital, that's all coordinated as well to try to prevent having patients go through what are designated clean areas as opposed to trying to facilitate going to lab, going to radiology and such, and not potentially contaminating other areas. So a lot of processes that are thought out and coordinated between all departments. And then up on the medical wards as well, that's all separated to an infectious side and a non-infectious side. So,
And we're particularly cognizant of our nursing home patients also. We have a completely separate secured area that they are only allowed to go through, escorted when they need x-rays, lab, things like that, so that we reduce any possible exposure as much as we can, because those populations, as you've seen on the news, are a huge risk for death.
so it's frustrating for patients that are used to coming up here maybe for routine laboratory tests or have been here previously for x-rays and that kind of thing. It's a frustrating process to take all of the precautions. We realize it's frustrating for patients, but keep in mind that it's equally frustrating for us to follow all of the guidelines and policies that we need to protect both staff and the public.
And we have a final plan in place now that should we have a major surge that overwhelms our current conditions, we also have a way to open up the entire upper part of the hospital as a COVID hospital and move our other patients, including ICU patients, into a completely separate part of the hospital that is clean.
And for the women's health patients, very similar processes as to what they've already talked about. We do have some sort of unique things to think about, such as C-sections and scheduled inductions of labor. And so we are calling those patients the night before to screen with those questions about symptoms and travel and those sorts of things. We are going to start just doing those labs on the day of C-section rather than having you come in a couple days early like we used to do. So we're taking some steps there to minimize visits and to pre-screen with questions the night before there as well. We do have a plan in place to resume more elective surgeries in the future. We haven't started doing that yet, but assuming that we don't get a big surge over the next week or two, sometime next month we will most likely begin doing our elective surgeries again at a slower pace, at a more in a thoughtful manner, starting with low-risk outpatient surgeries that can go home the same day. And so we'll be kind of updating the public on that as we go along. So we're thinking ahead. We're not at that point yet, but we have a plan in place for when that's appropriate.
And like Dr. Cunningham was talking about, we're aggressively screening pregnant patients, and if and when we can, not if, when we can get elective surgery restarted, this will pass. We will be actively screening those patients more aggressively too, because we have ability to do better testing and more rapid testing now.
Yes, and we are screening all of our pregnant patients. If they're scheduled for a C-section or induction, we are doing that with the test, with the nasal swab test, the week before they are scheduled to come in. If they drop in spontaneous labor and we didn't have time to do that, we're still collecting the test for epidemiologic reasons, but so we are screening all of those, or testing all of those patients we'll certainly do the same with the surgery patients in the near future too.
And even after we transition to doing some elective surgical procedures, as opposed to routinely wanting a family member or somebody to be available, we still have the restrictions as far as visitation or somebody being in the hospital waiting for the procedure to finish. Once again, a frustrating thing for all, but very necessary.
And if we do have a patient who is positive for coronavirus or COVID, so of the family members that can visit, they can only have one visitor who isn't actually allowed in the room, who can see the patient from the outside, unless if they are what we call terminally ill, which means that then at that point that they're, actively dying, and then that patient is allowed to be have that one person be with them. However, that one person then immediately will need to be quarantined for 14 days, and that's only if the patient is actively dying.
Okay, so we've had a question. What has the daily census been like lately in general, not just pertaining to COVID? Can you speak to that?
So it's been lower than normal. So part of it is that we are not doing elective surgeries right now, so we're not having those patients who are staying in the hospital. Part of it too is that, as you can imagine, the social distancing that decreases coronavirus also is going to decrease other illnesses, pneumonia, flu, things that people could also then end up being hospitalized for. Also, if you're not going out as much, there's less people who are going to, fall, break their hips, and so we are seeing a decrease in our census.
Same thing goes for the emergency department. Our numbers in general are down. Severely ill patients, for whatever reason, COVID or not, they're still coming to the ER, obviously, but lesser illnesses and lesser injuries. I think people are being mindful that we're not encouraging people to come to the hospital unless absolutely necessary. Or maybe they're frustrated by the process of not coming. That could be part of it as well. But in general, our numbers are down. And I think, other than COVID-related things, I know at least in Colorado, the same thing has occurred in general in emergency departments.
Even in California, there's doctors that I watch on blogs and lectures and things like that. They were commenting on, like Kent's son, Jose, which is a huge emergency department in California. Their volumes dropped to about a third of what their volume used to be, which is concerning because, once again, as we've talked before, if you have chest pain, stroke symptoms, you still need to be seen because people are staying away and these illnesses are still out there. But people are staying away because of their fear, which is reasonable to be concerned about COVID virus, but you do not need to fear it. Because if you got something worse going on, please come to see us.
Are there new symptoms that we should be looking for surrounding this virus? Because
They came out with 5 new ones. They have 5 new ones. The biggest one's going to be skin changes now. We think this might cause some small clots, and so in the periphery, especially in the feet, if you develop a rash there, like a rash that red areas that don't blanch when you push on them, that's one of the newest ones that seems to be more consistent with COVID.
More common in pediatrics too.
I mean, initially, everything was, most of the symptoms were centered around respiratory illness, but abdominal pain, nausea, diarrhea, those are things that, it's not absolutely new, but this isn't absolutely isolated to respiratory symptoms.
Loss of taste and smell is much more specific for this virus than the other non-specific symptoms. So you notice a sudden loss of taste or smell associated with some of these symptoms, that puts you at a higher risk for the COVID virus.
And because many people are completely asymptomatic on this, you can expect there's a lot more of this in the community than we know about. People do have symptoms. My home county, we had an inmate that we tested, who was from out of state. He was positive for COVID, never had a symptom the entire time. We kept him for 14 days, never developed it. So there's a lot of people like that out there, we feel. So that's the reason for the masks, number one. And number two, we want to make sure that we get testing for everyone, kind of, so we have evidence of the prevalence that we have.
Okay. All right, so does the hospital recommend the new antibody testing? What is the panel's feeling on that, or opinion?
We don't recommend it right now. I'm sure we're pretty consistent,
Yeah.
especially the at-home ones. They've been shown to be notoriously poor. A lot of them are imported. They've not been scheduled or approved by the FDA. And even if you have antibodies, we do not know at this point if that's going to provide any type of immunity. So it's not really helpful at this point.
Some of the antibody tests are not specific for the COVID-19. There's a lot of other coronaviruses that have been around for years.
The number 2 cause of the common cold is a coronavirus.
Yeah. So this is a special subset that's problematic right now. Anyways, you'll see antibody tests marketed, even home tests. I read a little bit about something that you could order a home test, and I don't think any of us have seen any studies that those tests are adequately validated. So it's not something that we would recommend.
And unfortunately, there has been definite scams selling home tests that are not even a test at all. So we gotta be careful of scams, hustles, the usual things that people take advantage of during these situations. But the big problem with the antibody test is we have no adequate testing of the test to know how good it is. All our lab tests have a range of how good they are. Like the influenza test is improved, but it's still not 100%. It's been around for years. And to know how good an antibody test requires lots of testing. And we just have not gotten there yet.
And we do not know if the antibody being present does anything for you at this point.
Yeah, and we don't,
know
yes,
if
I
it's
agree.
protective.
Don't know if it makes us immune.
Because they actually had done a few studies where one of them showed that people who were actually negative then turned positive later who had already recovered from it. So kind of like the normal coronavirus, that for some reason our bodies don't mount the same response compared to, you know, other like flu strains and things like that. So really, even if you have had coronavirus, that doesn't mean that you're then immune to future or even in a few months if you were exposed to it again.
And the problem with those tests, though, they didn't know if that was live virus they're finding or dead virus.
Mm-hmm.
See, this is the problem with testing. See, you can see we're always discussing these things because when you do a test, you're doing to look for a certain endpoint, what we call, what we want to find. And then we discover all these side issues and we don't know what they mean.
Probably more interesting to an epidemiologist.
Yes.
Than to a practicing physician.
Yes, I agree.
So all of us are trying to stay as current as possible with all of this. It's an unending job because things change so quickly. But if there is a test that becomes available that seems like it's reliable, we would be the first to, well, just like any other medical providers, we would seek that out. So I don't think there's tests out there that we're necessarily unaware of that are being marketed on the internet. We would love to have additional testing. We've made great strides with the testing availability that we have right now. And if an antibody test came out and it was beneficial to the public or for clinical care, we would be very aggressive to try to obtain that.
Is hydrochloroquine still being used as a treatment?
No.
Basically,
The hydroxychloroquine, I mean, there was some initial hope anyways with that, despite what you've seen from political commentary and such, it really has not panned out to be beneficial. There's a lot of people that inquired about I mean, especially people that have a suppressed immune system, wondering if they should take that as a preventative action for COVID. There's no data to support that use. And even more, for inpatient setting, it's not something that has followed through to be effective.
They have done some reasonable studies in the United States. They're still studying it, don't get me wrong. And if things change, we will reconsider it. But the one good study that was properly done in the United States showed no benefit and some increased death rate in a VA hospital.
Yeah, I mean, the medication in and of itself has some potential harm, completely unrelated to COVID. So, like other medications, you have to consider the benefit versus the risk of all medications. And right now, there does not seem to be a benefit, and there are no risks for the medication.
We're waiting for a large study being done right now in Australia for using it earlier. The studies that we were talking about, they used it very late when the patient is fairly sick. And now they're doing some where the symptoms are much milder. And so it's a much bigger study. It'll have a lot more power to it once it comes out and it's not finished.
Yeah, and there's a lot of other things that you'll potentially read, vitamin C, zinc, remdesivir. That's the newest one that does show some potential hope. That's only an intravenous medication. There's some studies going on with medication called famotidine, which is Pepcid, that you can buy over the counter for hyperacidity or ulcer symptoms. But don't go out and buy a bunch of Pepcid. The doses that they're using for the studies right now are much, much higher than the standard dosing for gastric hyperacidity, gastroesophageal reflux, ulcers. It's not effective if you just take a massive dose of that as opposed to intravenous use of that. The vitamin C that's been recommended, once again, vitamin C, I'm kind of an advocate of that. If you feel a cold coming on, that kind of thing, but the doses that they're using or suggested for COVID, you cannot establish those serum or blood levels of vitamin C by taking it orally. It's only for intravenous use as well, and that's something that had been suggested, but once again, there's nothing that has made a dramatic difference.
And these studies, though, show nothing yet because they're ongoing. So even with vitamin C and the Pepcid IV, we have no results, so we know nothing.
Yeah. So anyways, the bottom line is don't go out and buy a bunch of Pepcid and think that that's going to protect you.
Yeah, don't run on Pepcid like toilet paper.
Yeah. Yeah. Same thing with the vitamin C, and then obviously the suggestion a week or two ago by political figures of disinfectants. That's definitely not something that you want to put inside your body. There's none of those that you could take orally or intravenously that is going to not cause problems. So, very toxic.
Will the hospital keep all of these special processes in place through summer? What are you predicting at this point?
My guess is yes.
Probably.
Yeah.
Probably, unless we're very lucky.
Yeah, it's an ongoing process. We have a steering committee that meets twice a week for updates on all levels of this, and including that is the processes within the hospital. But I suspect that we are going to have to continue with precautions.
Do you anticipate that we will be seeing coronavirus through flu season? Is this something that we're going to see as an annual an annual process or something that impacts our communities such as the flu does?
It seems likely that this will reappear or continue to flu season, likely. When a pandemic occurs, basically, unless we get a vaccine or really good herd immunity, that defines that that virus will be with us for 100 years, basically. That's what a pandemic means. The virus will be with us. That's why we have to get a vaccine, or if we don't get a vaccine, hopefully people do get immune and the virus then cannot spread so severely as it spread before. What little I know about epidemiology, I just told you.
So can you explain herd immunity?
Herd immunity, yes. Basically, it's like the measles vaccine. Let's use that as an example. Okay? If you give enough people immunity with the measles vaccine, which used to be a horrible disease when I was a kid, deaths and everything else, and the measles virus is probably 5-fold more aggressive and spread
And it's
than this
airborne.
one.
And it's airborne.
It's airborne. It's worse than the droplets. And so when enough people got vaccines, we rarely saw measles after that. And then when vaccinations dropped down, the herd immunity dropped, and now measles has come back to haunt us. Because it never went away. And this is what I fear potentially will happen with a COVID virus, because measles was a pandemic.
And the idea behind herd immunity is the fact that, like, so let's say you have like a big, so the idea is like a big herd of people. So if nobody's immune, then every single person that this one now touches this one, they all get infected, those touch these, and they can get infected. The idea with herd immunity is that even if one's infected, if all of their close contacts are immune and they can't get infected and spread it, then it would stop with that one person. So if enough people are immunized, then you can't keep spreading it. So, you know, like I couldn't spread it if we had a huge herd and this person was not immune, this person wasn't immune. There's no way it can get passed through all these other people to that one if these can't carry the disease. And so that's kind of the idea behind herd immunity, is that if enough people are immune, you have less vectors to be able to spread it, and that it can't go past one person. So even if you do get one who's sick, it won't spread anywhere else, which is the current problem with coronavirus, is every infected person tends to infect about 2 to 3 people, 3 to 4, and then before they realize they're infected, they keep spreading it too.
And the benefit of herd immunity is that it protects the most immunocompromised, the most vulnerable in the population. So someone who cannot get immunized for whatever reason, say they're allergic to a component of the vaccine, or say they're a cancer patient who is getting chemotherapy and their immune system can't mount a response, the immunity of the people around them helps protect them, because their contacts are not going to get ill and then spread it to them. So herd immunity not only protects those who are themselves immune, but also protects the vulnerable in that population.
So that's one of the true benefits of vaccines in general, even if somebody isn't necessarily concerned about themselves, thinking that we're all in this together, being vaccinated and using social distancing, the face masks and such, even if you're not concerned, it can have an effect protecting your loved ones or other people in the community that are at particular risk.
Thank you.
Herd immunity generally requires a vaccine to actually happen.
All right, so now we have a question. I've seen information stating that ventilating patients actually is more harmful than helpful. Is that true information or false? Also related, I've seen a report that a blood transfusion is actually what the treatment should be. Is there any truth to that article?
So it's...
Lots of information.
I was going to say, from the standpoint of having somebody on the ventilator, we do our best not to intubate somebody and put them on a ventilator, as opposed to other conditions where we might use that earlier on in the treatment. The recommendations for COVID is to be as aggressive with all modalities before putting somebody on a ventilator. So the statistics of when somebody is on a ventilator, coming off or improving, that could be a manifestation just because those are the most severely ill patients that get put on the ventilator. But we're much more aggressive in this situation, trying everything that we can do, and using innovation and being on a ventilator as the absolute last resort.
The thing with the ventilator, yes, there is a high mortality rate for this particular disease when you are on a ventilator. That's the reason that we have now several different ways to ventilate people to reduce that mortality, because we used to have a standard protocol called the ARDS protocol. And we found that that was problematic in this particular disease. What people are not aware of, if you get sepsis from a bacteria, from pneumonia, the mortality rate from ventilated patients is 40 to 50% also. This number of 80% is higher, but anytime a really sick patient gets on a ventilator, people do die from this various diseases. What was the second part of the question?
Oh, it was the plasma.
Convalescent
Oh,
serum.
Or even worse, blood transfusion.
Yeah, the plasma, convalescent plasma, is being experimented on, and there was a doctor, I forget where he's at, 2 doctors that I followed that were starting to do this, and we don't know if it's useful. They found it useful in the influenza epidemic potentially in 1918, the Spanish flu. It theoretically should work, but once again, the problem is we don't know how good the antibody is. That's why they're doing these experiments. And to get convalescent plasma to do this usually requires you contacting the CDC directly, the FDA, and getting special permission for one patient every time.
So that would mean taking plasma from somebody that previously had the infection.
Yeah, that
Now,
has
there
antibodies.
Yeah, there were suggestions early on, I guess a month ago or so, that
Blood transfusions.
yeah, that blood transfusions in general would be potentially part of the therapeutic intervention or treatment, and just trying to look at different physiologic mechanisms involved in the disease process, and that's not something that really has followed through and is recommended for standard care, standard therapy.
We thought it was a hemoglobin problem initially, or people thought it was a hemoglobin problem, but now we feel it's not.
Yeah.
So.
Thinking of the hemoglobin was affected and couldn't transport the oxygen to the rest of the body, the vital organs.
But now we know we can't find that virus in the red blood cells, so.
Yeah.
Yeah, and it turned out to be a false lead on our part, like several false leads we've had, unfortunately.
Yeah, everybody's scrambling in general and trying to look at the physiology and figuring out what's unique to this virus. And so there have been a lot of different things suggested, that being one of them. Going back to the putting people in the ventilators, the parameters or the use of the ventilators is kind of unique in this situation as well, as opposed to other respiratory infections. They've scrambled to look at lots of different medications that a lot of you might have read on the internet or heard on the news.
Fortunately or unfortunately, we've learned from places like China and New York and Washington and places like this. And so I think touching on the ventilator question specifically, I don't manage ventilators, these docs do, but maybe managing these patients, the COVID patients, a little differently than they've traditionally managed respiratory distress patients in the past, we've learned some things from New York and some other places. But just touching on the question specifically as to whether or not ventilators are harmful, I think you have to be careful about what we call a selection bias. If you're only looking at the patients who are already on the ventilator and are the sickest, and they're by definition the sickest because we've tried all these other things before putting them on the ventilator, that's not the average COVID patient. There's lots of COVID patients, but we're only picking out the sickest of the sick and then looking and see how they do on the ventilator. Well, they're gonna have a high mortality rate, unfortunately. And so we just have to be careful to recognize the bias when we're looking at those patients who are already on the ventilator. It's not including all those patients that we've already treated with high flow oxygen and all these other things. So just realize that when you're asking that specific question, you've already excluded all the other people that we've helped to stay off the ventilator.
And when we do these other things like high flow oxygen, CPAP, BiPAP, all these things more aggressively than we used to, we keep a significant number of patients not being intubated and put on a ventilator. So that increases the selection bias. I agree.
Yeah.
Which is why the percentages have gone up likely from 50% to 80% for mortality, is because now the ones that are getting onto the ventilator are the absolute worst of the worst. Otherwise, they would have been maintained some other way.
Okay, so do you recommend the flu vaccine this year?
Yes.
Yes, absolutely.
I will get it
As soon as it comes out.
because especially if you get both diseases at the same time, that could be a huge disaster for you.
Yeah. I think one of the questions earlier was, do we expect a resurgence or along with the flu season? And the projection is that that's a very troublesome or worrisome proposition, that even if we get continue with the flattening of the curve and they get decreased numbers throughout the summer when influenza season hits, and if there has not, if we have not gotten a vaccine for COVID in the meantime, that we're going to get a secondary surge or worsening of the whole situation. If you have a different type of respiratory infection, and then you have COVID on top of that, that would be, well, the illness could be worse, the complications could be worse, so yeah, that's a huge issue.
And it's especially important in children, because children, for some reason, we don't know yet if it's anatomically, specifically, but COVID does not seem to affect children as much, and if they do end up getting it, they don't end up getting as sick compared to adults. So really the biggest threat to children are going to be these diseases that can be prevented through vaccinations. So for kids, definitely keep bringing your children to the well child checks, and then that way they can get immunized against all the other diseases that we typically immunize them against.
And
So even if
influenza also has a higher death rate in children than COVID. So it's more dangerous to your children, influenza is.
So to keep in mind that even if you're not overly concerned about the complications of influenza, or when we get COVID vaccine from your children, keep in mind that when they go to daycare, they go to school, even if they do not have symptoms or minimal symptoms, they're bringing that back home and putting the family at risk, and potentially other loved ones or people in the community at risk. So get your vaccines.
All right, can you please talk about the new medicine they are testing in Colorado? Is this something that will begin in Wyoming as well?
Respiratory maybe?
Right.
But yeah, it's antiviral. I think we already addressed.
Yeah, it's being tested internationally, nationwide, in multiple sites, multiple centers.
Yeah, I know it was on the Denver news this morning,
Yeah, okay.
but it's definitely not unique to Colorado as far as them specifically testing the medication It's being tested throughout the world.
Is this in a clinical trial there in Denver?
I think there's 2 hospitals that are participating someplace in the Denver area. But that's being studied widely, and right now that's the best candidate as far as treatment. Once again, that's only intravenous use for
And it's
hospitalized patients.
not even distributed to hospitals, if I understand correctly. It's investigational, basically, is that right? It was designed for Ebola and it didn't pan out.
Yeah.
Failed Ebola, yes.
So that's its only
Yeah. and
prior clinical use, is my understanding.
That's my understanding too, yeah.
Okay, so how many strains have been found?
Just the one, right?
I've heard there's 2 distinct strains, but they're close enough together that one vaccine would be able to do it.
Yeah, there's potential, what I've seen is 2 strains, one on the East Coast, one on the West Coast. And they're very, very similar though, so if you develop a vaccine, it should cover both.
As opposed to like the respiratory coronavirus that we get the cold from, there's lots of variety there. That's why they can't get a vaccine for that one.
Yeah, there's 4 to 23 of them or something.
Crazy numbers.
Okay, so at this time, we're nearing the end of our Facebook Live event today. If there are any other questions, we'll give you a few more minutes to submit those, and then if you think of something later, as always, please feel free to do that, and we will follow up with those questions. Is there anything else that the panel would like to add before we close today?
Yep, so one reminder that our clinics, we do have split up into anyone who's acutely ill, acutely infected is being seen at the FPC. That one's on 3rd Street in Spruce. However, anyone who is coming in for chronic visits, well-child visits, non-infectious things, like if you have a worsening of, your fluid status from like congestive heart failure, things like that, you're going to the Wagon Circle Clinic, which is now known as the Visiting Specialist Clinic, but formerly Wagon Circle. I just say both of those because not everyone's heard both of the names. But keep in mind that also, even if it's something where you're very nervous about coming in, at least setting up telehealth, we don't charge any additional cost to doing telehealth services. So if we call you, we can set it up where we have a Zoom visit, we can physically see you, we can get some other measurements in place. So it's really, really important because we are seeing an increased number of deaths for diseases that typically people would have had, surgery for or come in for, but because people are nervous about coronavirus, they don't end up coming in and seeking help for. So just keep in mind, we do have the 2 clinics that are split, so then that way we can encourage you to continue on your maintenance for high blood pressure, congestive heart failure, anything like that, so then we can help prevent those populations of people from being hospitalized and utilizing telehealth if needed.
And the Hannah Clinic is still open, of course, and does have an isolation room. We can't separate clinics, but we do, and we still have regular visits. When I was out there last time, I saw 10 patients, and they were all in the clinic because I go out there for half days, basically. Okay.
Okay, so we did have one other question come through. If there's anything that can be said to this, can you release any information about the condition of the positive COVID patient who was transferred to Wyoming Medical Center from MHCC?
I think we said saying he's in critical condition. I don't think we can.
Other than that,
We can't talk, for anybody, we don't talk about patients' conditions.
sorry.
So, I guess my last comment would be that with them opening things up for people not to get a false reassurance that this is all dwindling away or not a currently active issue, even if you don't feel concerned for yourself or that you're at risk, keep in mind that it's we're all part of the team in various ways, and everybody can contribute by the social distancing, the wearing of masks, and trying to protect our whole community as much as we can.
And consider getting testing if you have symptoms.
Yes.
We can test you now.
We got some tests.
All right, so with that, we're going to close for today. Thank you, everyone, again for joining us, and feel free to share this event and help continue to educate our community. Thank you.